Good afternoon, everybody, or rather, I guess it's good morning.
Good morning.
It's quite a pleasure to be here to talk about this very important issue of disaster recovery, resilient communities, and actually the role of public health and the communities themselves in preparing for these events. If we could put up I think, slide number 3, that I think was provided by one of our speakers. The problem of public health disasters has been growing over time. And I don't think that it was the one with the map, a couple back. Thank you. And it's important to keep in mind that when we're talking about disaster preparedness, we're talking about events that not only have enormous economic impacts on communities, billions and billions of dollars that are losses from either real estate, commerce, the interruption of people's lives, but they're also events that have enormous impacts on health. Not only very direct and immediate impacts such as mortality, longer-term impacts on risk for mortality, but also impacts on mental health, impacts particularly on children who may be displaced or may suffer a number of problems as families suffer economic losses. And so that it's important that we're all involved in responding to these. Some of you may have been here last night when in the closing session, Jose Andres spoke to us about why it is that he, as a chef, is involved in response to disasters. And he said something that I think that's very important, which is how can we not be? When our neighbors and our communities are impacted, our friends are impacted, and that they need us to be there. And I think that it's truly inspiring how he has gone around the world as a chef to address this. We have, though, today a panel of experts who have a lot to share with us about how we organize ourselves as a society and how perhaps we could be doing a better job of doing that. To my immediate left, we have Elizabeth Disco Scherer. She is the CEO of Disaster Services for the Society of St. Vincent de Paul. But she's also a national leader in the National Voluntary Organizations Active in Disaster, the so-called FOAD group that is very organized around being in place within communities to provide disaster support. She's involved currently with the response to all of the named hurricanes that you can remember, whether it's Matthew, Maria, or Imelda, or Harvey, as well as the fires in California. We also are fortunate to have with us Dr. Nancy Knight, who is with the U.S. Centers for Disease Control and Prevention. Dr. Knight has had a very distinguished career, mostly in government and in global health. She was stationed for a number of years in the CDC South Africa office, currently in Atlanta for the last few years. And she's very involved with the development of global health systems and approaches that are able to make us more resilient to any kind of disaster, whether it is a natural disaster, an infectious disease, or others. And so we look forward to hearing that perspective. We also have with us today Bob Ottenhoff, Robert Ottenhoff, who has been a real leader in not-for-profit philanthropy and entrepreneurship, and at present is CEO of the Center for Disaster Philanthropy. Of interest for me certainly is that prior to that, he was president and CEO of GuideStar, which many of you may know is one of the most reliable entities in the industry for tracking not-for-profits and for promoting higher quality data that allow donors to understand what not-for-profits are doing and help to promote best practices in the whole industry. And last but not least, certainly, is Dr. Umair Shah. Dr. Shah is the health officer, really executive director and a local health authority, I would say health officer, but for Harris County Public Health, which is the accredited public health agency for the third largest county in the nation. He's responsible for the health and safety of 4.7 million people. And I think many of us could appreciate how the Harris County area has particularly been impacted by natural disasters and other threats over the years, including infectious disease threats. He was an emergency medicine physician before he found his way to public health. And he also has held a lot of leadership positions, particularly with the National Academies of Sciences, the Centers for Disease Control and Prevention, and many others. I think every time I turn around, I see Dr. Shah advising the nation about these issues. So it's my job to kick this off, and obviously, you know, we're aware that these disasters are incredibly important, and you know, we're here today in a week when there are many people in California who've been evacuated from their homes, are sitting there feeling uncertain about whether they'll have a home to which to return, and if so, what will be the state of that? Are they insured or not? Many of them are not covered. Many of them will return home and maybe on the surface will be fine, but their lives nonetheless have been disrupted. They have been put through a very trying set of circumstances. And so, you know, how we help communities prepare, how we help communities cope is very near and present to us right now. There are people here at this conference whose homes are evacuated due to the fires in California. And so these are issues that are not just problems for someone else. These are issues that impact all of our lives very directly. And I actually thought I'd start by asking each member of the panel to give us their perspective on disaster recovery and resilience, and what they think are the most important steps to be taken to enhance community resilience and preparedness, and perhaps starting from the federal and global level with Dr. Knight, Nancy Knight, if you could give us your perspective.
Thank you, Lynn, and thanks to Milken Institute for including CDC on this panel and for this discussion. CDC's overall mission is to save lives and to protect health. And we're protecting the health of Americans and people all over the world from threats that our health might face, whether those threats initiate domestically here, whether they initiate globally in other countries, whether they're due to infectious diseases or chronic diseases, or the public health consequences of a disaster. So I'll talk a little bit about what that means for CDC on the global side of things, which is where I primarily focus, and how that relates to CDC's overall priorities. We have 3 overall priorities for the agency: to end epidemics, to be able to positively impact health security. And that is related to global health security as well as domestic preparedness, that linkage between the two. And so along those lines, on the global front, what we do is we work with countries to help them to build their public health systems or to improve their public health systems, so that if a disaster strikes, they are able to have surveillance systems in place. They're able to have a workforce that's able to go out and assess the needs that those affected communities might have, that they're able to have diagnostics in place to look for public health outbreaks or consequences of a disaster. and that they're able to do that through a formalized incident management system, through an emergency operations center using the incident management system. Now, when a disaster strikes, sometimes those systems that are in place are also impacted. And where maybe you have had a strong laboratory network that gets destroyed, like we saw in Haiti after the earthquakes there. So another thing that we do is we work to help to provide assistance to those countries when they ask for our assistance. And from my division, we roster experts from across the agency that can be deployed when assistance is needed, whether it's an outbreak like we have happening with Ebola right now, or whether it's after a natural disaster like we did in Mozambique after the cyclones. In terms of the challenges that we face, I think there are a number of them that we'll want to dive into today. But since the focus of this session is really around resilient communities, I do think that that's a particular issue that I'm interested in talking about with the other panel members, because often communities feel disconnected, and then you place a disaster on top of that, and that can serve to further that lack of connection that they feel. So that's a very important aspect of the work that we do globally, the work that we do with states when states require assistance, and I'm sure the work that the other panel members do as well.
Okay, thank you for that perspective. I thought it might be useful to kind of zoom down to a more local level in public health and hear from Dr. Shaw about your perspective coming from Harris County, Texas.
Well, good morning. Thank you, Lynn, and thank you to our panelists. And I do have to start by, I think everybody here knows I'm from Houston, so I do have to show the shirt. I apologize. I know. All right. Sorry, the disaster has already started, so I just wanted to go ahead and put that out there. But go Astros, and
you're a brave man.
I'm a brave man, and congratulations to the Nationals for having such a great season. Hopefully
that did take courage. That took a lot
That's
of
right.
courage.
That's right. So I really do want to just bid you greetings from Texas, from Houston, and really an opportunity for us to have a conversation about really what our community has gone through. And I'm going to speak very fast because I do actually want to show a few images to give a case for why, as you just heard from our CDC colleague here, that there's really a lot about what happens at the national level, but really what happens at the local level. I was honored to represent as the president of the National Association of County and City Health Officials 2 years ago as representing the 3,000 local health departments across the country. And we are oftentimes really challenged by really ensuring that what happens at the federal and state level really translates to the local level. And as you can imagine, that really translates into a community such as ours. I call it the hashtag Invisibility Crisis because we do have an invisibility crisis in public health that oftentimes people don't know what we do when we do the work that we do on their behalf, and it's really important for us to be thinking about that, even though we don't have the bells and whistles of the ambulances or the emergency department physician or the hospital, et cetera. Next slide. Harris County is big, diverse, complex. We're spread over the size of Rhode Island, and we have 4.7 million people. And I think what's really challenging for us, next slide, is the fact that, again, as we do our work, it is largely invisible. It really gives us an opportunity, next slide. There you go. That it really is behind the scenes. And I think that's the real challenge when you pick up dangerous animals, respond to emergencies, certainly inspections at restaurants or all the different things that we do for the environment. It is oftentimes behind the scenes. Next slide. But when we're looking at medicine and public health coming together, we really do need to be thinking about all the different emergencies that communities are facing. Next slide. And as we do that, here is what we have gone through. And I'm originally from Cincinnati. I'll tell you, we've had in Cincinnati maybe 3 or 4 emergencies in the period of time. And my friends ask me why I'm in Texas. These are the kinds of activities that our community has gone through. Everything back to Tropical Storm Allison in 2001, the nation's first biowatch hit in 2003, Hurricane Katrina evacuation to our community with 27,000 people at the Astrodome, Hurricane Rita evacuation where we tried to get out of town, but we were stuck on freeways, Hurricane Ike that actually hit us, and certainly a lot of infectious disease responses from H1N1, Ebola, Zika in between, and then certainly this last year where we've actually seen last few years with Hurricane Harvey, tropical storms, including Tropical Storm Imelda this year, resurgence of measles, and now we've had 3 petrochemical fires in our community just in 2019 alone. It is never a dull moment in our community. I always feel like I'm the wrong person to talk about the importance of coming to Houston to come visit. Next slides. And you can just go through these images if you don't mind, if you just fast forward these. Hurricane Katrina, Hurricane Rita, Hurricane Ike, Ebola, which was in Dallas, Zika, Hurricane Harvey, the industrial fires, Tropical Storm Imelda. And I want to stop here, which is, this is the most important thing. And when the Astros won in 2017, it really did show a lot of resilience for our community. But we have to remember that statistics are truly stories of people. And this is Zioma, who shared with me the story. I had driven about 2,000 plus miles in my own car for about a week or so after Hurricane Harvey, knocking on doors and talking to people. Zioma's story was a woman who she and her family evacuated to an area hotel. When they got to the hotel, the air conditioner, every time it came on, it apparently would drip into the drip pan underneath. Drip, drip, drip. Every time she heard that drip, it would flash back to the water that was raining and dripping in as it engulfed her neighborhood. And she started crying. And that's post-traumatic stress, and we know that stays with people, we don't know, a few days or a lifetime. And we have to remember these are the stories, but yet we went back to her a year later, and she was better. And that's the resilience, that's the ability to bounce back, and I think that's absolutely critical. So with that, I'm going to go ahead and stop there. I've got a lot of images, and I've got some great video, but I also have great panelists, so let me go ahead and stop right there.
Thank you so much, Umair. I think that last quote, statistics are humans, with the tears wiped off. It's a great segue to our next speaker, actually. Elizabeth, just go share. You have so much very up close experience with so many different disasters all over the country, and I think we'd love to hear your perspective about what we need to be considering.
If we could go to slide 16. St. Vincent de Paul is an international organization. We're a Catholic lay organization, a voluntary organization active in disaster, and I'm the CEO of the U.S. branch of that. The slide that you're seeing, I always say disasters reveal the underbelly of society, and we look at the social ills, and the 3 pics that we have there. This is in the United States. This isn't in a foreign country. The one is West Virginia, and these were the floods of 2016. And we had families that after the disaster hit, because there was not really a system in place of communication, because believe it or not everybody has internet in the United States or access to smartphones. So we had families that were camping out after the disaster in tents. They were bathing in a river that had E. coli in the river. And, these are our problems. The other one is in Florida. We had this young mother was in an isolated community, and the baby was ill, and we were able to get services to them. And the last one was in Puerto Rico. Puerto Rico was like nothing I've ever seen. I was on the ground 10 days after Maria hit. We were trying to set up the emergency response systems, but because the infrastructure was destroyed, it was very difficult. So we set up something called Parish Recovery Assistance Centers to try to be the boots on the ground. And we saw 7,000 households in a 2-week period. The picture that you're seeing, we did a kind of a short medevac station. I've never seen so much disease. We weren't prepared for that. As a voluntary organization, we needed the public health officials there. It was very scary. We were also seeing a lot of children that were orphaned because the parents had died, and it was a crisis in identifying the bodies. And so I can tell you, for our volunteers, we kind of had a lot of post-traumatic stress from that incident because we really weren't prepared for the pain and suffering that we saw. So if your question about how to prepare, communities need to work with, Puerto Rico has a voluntary organization group, Active in Disaster. The United States, we have voluntary organizations. We try to meet in advance of a disaster and plan how we will respond if officials can't get there immediately. So for all of you all, I would say you need to be prepared to individually respond for at least 72 hours because the officials may not be able to get to you. So I always recommend that people have their own emergency response plan. Medical records are critical. You need to have a way digitally to have access to those. The same with your insurance records because things may get destroyed and you may not have time to grab that go-ready bag or whatever.
Thank you for that. As our last panelist, Bob Ottenhoff, how do you view this from the broader perspective of philanthropy more generally?
Right, so I'm going to focus on the philanthropic response to disasters, and if you could go back to that map for just a moment. Americans tend to think that disasters happen to somebody else, right? It's somebody from overseas, or it's someone who happens to live too close to water, and it's only when it actually happens to us that we begin to think about it. So we sort of have this temporary view of disasters. I'd like to show this slide because this is 2018. We had 14 disasters with $1 billion or more in damage, and that doesn't take into account the human toll. But what surprises people is to note that only 2 of them had a name, right? Hurricane Michael in northern Florida, and then Hurricane Florence. The rest of these disasters, droughts, fires, floods, didn't have a name, but still caused lots of damage. And so we need to think as a country that, look, disasters are increasing in frequency, they're also increasing in intensity, and it should matter to me and to my community. Next slide, please. So because we think it's for somebody else, our response in philanthropy tends to be very, very reactionary. This is a slide from 2017. It only shows foundations and corporations. I would say the individual response to this was probably at least matched this and maybe was even a little higher than that. But you can see the outpouring of support for Hurricane Harvey begins to drop with Irma, gets just a small portion of that for Maria. People ask me, well, was there donor fatigue? And I say, well, there probably was a little bit, but there's probably disaster fatigue going on here too. Because our response suggests, well, look, if I give a contribution, then this is fixed, right? Then, so why are you coming back to me to talk about more problems? Because when I made my contribution to help somebody who is in an emergent situation, I thought it was all over. Next slide, please. Here's what generally happens in disasters, and this is probably being kind. There's this huge outpouring of support. It's often driven by media coverage, so the more media coverage, the more dramatic pictures, the more the donations. Hurricanes drive a lot of donations because there's a 5-day buildup, right, of breathless reporters, first looking at all the spaghetti lines and then standing on the beach with their hair in the wind talking about this hurricane that is 3 days away. So there's this dramatic buildup, and that drives a lot of contributions. Floods, maybe there's 1 day of media coverage of a dramatic picture of getting grandma out of the attic with somebody's boat. But then the long story of the muck out, the rebuilding of a community that could take months, gets no media coverage, and then as a result gets very few donations. So we see donations peak after 3 or 4 weeks and then pretty much peter out. Next slide, please. So every year we do an annual survey. We're just about to release it. It's called the State of Disaster Philanthropy, and we look at all dollars going to disasters from all sources, and this is done worldwide. This happens to be from 2016, which actually was a pretty good year in terms of the percentages I'm going to talk about. But what we roughly see is 50, 60, 70% of all dollars from all sources goes into immediate response. About 10% on average goes into planning, preparation, mitigation, building resilient communities. Roughly about 10% goes into reconstruction and recovery. Now I'm talking here only of philanthropic dollars. In the big picture, philanthropic dollars are relatively a small percentage of the crazy quilt of funds that go into disasters. FEMA, municipal services, state services, insurance is dramatically more. But the philanthropic dollars are important because they're immediate. They probably have fewer strings attached. They can either go for immediate activities or they can go for more patient, long-term activities. So the philanthropic dollars are really critical to be used in a strategic way. And that's really the focus of our work, is to try to get out of the reactionary approach we're in right now, to think more holistically about disasters, think about the full life cycle of planning, preparation, mitigation, long-term recovery. We ourselves at CDP manage funds on behalf of foundations and corporations. We put all of our dollars into mid to long-term recovery and with a focus on vulnerable populations. We're still working in Texas. We're still working in Puerto Rico. We'll be in some of these communities a long time. So in a little while, I think I've got one more slide. Go to the next slide, please. Just to remind everybody, recovery takes a long time. The real work of disasters starts in the 3rd month and can go on for years afterwards. And for us in particular, the health-related issues are one of the most critical. So I've got some other slides, but we'll get to those later. Thank you.
Okay, so I'd actually like to key off of the slide that was 2 slides back, I think slide number 6, the graph showing the foundation giving, because I think it makes a very important point, not only in terms of philanthropy, but I think also government responses and other responses, I think, tend to follow this same kind of pattern, which is that the bulk of the effort is in the immediate response, and that I think we all agree from what the comments were that we need to focus more on the longer range efforts around community resilience and capacity, reducing the risks, mitigating the risk, building the capacity in communities. And so I was just wondering if each of you might have some ideas about ways that we might go about doing that. Perhaps in the same order, starting with Nancy.
Sure, thanks. And I'll use your term of the crazy quilt of the funding, because I know the U.S. government is part of that crazy quilt as well, right? The resources, and kind of to your question, Lynn, are about resources that are available on a more on a continuum of what's needed for both preparing for a potential disaster and response, as well as during the actual event of a disaster response. And we have, through the US government and CDC specifically, we have different ways in which we try to address that. So on that kind of continuum of resources that are provided, the CDC has the public health emergency preparedness resources. So in this past fiscal year, we provided about $620 million to the 62 kind of states and territories domestically for them to be able to utilize together with resources from, local resources from the states and other partners to address their public health preparedness needs. One example of that from an infectious disease outbreak is the measles outbreak in Washington state. So they were able to use those dollars through the incident management system that they had helped to capacitate and the people within that system to be able to use that for the measles outbreak too. So that's one way in which we provide support domestically. And there's an ability for states to get additional resources too when there is a more significant disaster that hits. Globally, we have, as I mentioned earlier, we've been focusing on building these public health systems to help to better mitigate and prepare for disasters and public health threats. The wake-up call within that for us, for the world, I think, was the Ebola outbreak, when we really saw the weaknesses that existed from a national level all the way down to a local level in these countries to be able to deal with such significant public health threats. And so Congress provided us with resources to be able to control and contain the outbreak at that time, but also to be able to continue working with those countries and other at-risk countries through the global health security agenda. So we had $600 million for 5 years to help them to rebuild and to work on those systems. Those 5 years ended last month, the end of fiscal year 19. We have some other resources that Congress has provided. $50 million in FY20 for global health security, and another 50, sorry, did I say FY20? We don't have FY20 yet. 50 million in FY18 and 50 million in FY19. In addition to that, in FY19, for the first time, CDC has received resources for an infectious disease rapid response fund, 50 million for that, which if the secretary declares a disaster, we could draw upon those resources to use that to respond. So we have different allocations of money. I think as you've mentioned, disasters and those post-disaster where we focus on the public health impact of that, that can go on for years and years and years. We're still in Haiti. We're still fighting cholera in Haiti. We're still working with them on rebuilding their public health systems, and that's been 2010. So that's an extended period of time. We're still in West Africa. We're still working with those countries. You see examples of this all around the world. Those needs will continue to exist within those countries. So that's where we have to be strategic. We have to look at, with the resources that we get and those resources that are coming from other partners and going into, as you see on the slide, into specific aspects. How do we make that crazy quilt maybe a little less crazy, right? How do we work together to put our resources together to put our expertise together so that we can address the most important gaps that exist?
And I would just say that it's great that you're doing the work you do. CDC does great work. The level of funding is not impressive, in comparison to other. If you look at NIH research.
I was very impressed by the amounts that Representative Waters was talking about on the first day for Alzheimer's research.
For Alzheimer's research, and I think that the public health system in this country as well as globally, it does not work perfectly. And I'm guessing Dr. Shaw may be able to give us a little bit of perspective on that. I mean, there's certain funding that flows from CDC to the states. Hopefully some of that ends up in local areas, but I'm imagining that many of the resources that you were able to pull together are local resources as well, that the federal government is not providing a substantial amount of support.
Sure. Thank you, Lynn and Nancy. Thanks for those comments. And I have an incredible amount of respect for the CDC and the work that our federal partners do. They just do an amazing job. So I just wanted to acknowledge that as well.
Thank you.
And I absolutely. And I wanted to make a comment about during 2017 with Hurricane Harvey, and staying with a little bit of the sports piece here, is that J.J. Watt was, as many know, Houston Texans football player who set out to raise $200,000. In the process, wound up raising $37 million. And I think it just shows that oftentimes it's not us, that it's really those champions for community voice that are able to then articulate what the need is and then be able to get that out. And sometimes it's not the government or nonprofit sector, but it really is somebody who is living that, but also is able to bring people together. Where I wanted to go with, Lynn, your question, and Nancy, what you just mentioned is, if you could go to slide 32, and I mentioned this at the very beginning about the real challenge that we have in public health, and I call this 32. There you go. Make sure I have the right. Just want to make sure I have the right slide before I launch into what I'm about to say. 32? Coming up? Almost? Oh, okay. Sorry, I don't know why I'm looking at the video cameras in the back. I should be looking over there. So, so what I really wanted to describe is that there is this invisibility crisis that we have in public health, and it's a real challenge. And what I say all the time is that we are truly the offensive line of a football team. Everybody focuses, again, apologies for that. Go back to 32. There you go. On the quarterback, number 4, and I always feel badly for number 68. Nobody has any clue who this person is. He's blocking, sweating, doing all sorts. His back is turned to the camera. I mean, that's how nobody knows who he is, and yet that is really public health. We're the offensive line. But where the metaphor breaks down is that in public health, in the offensive line, if you have a great season, great game, you will actually continue to invest in that offensive line, right? You don't come back and say, let's bring the 4th string people in because we had a great Super Bowl season. But in public health, that's exactly what we do, right? Measles cases go down, we don't need public health, they go back up. TB rates go down, we don't need public health, TB rates go back up. This hashtag invisibility crisis is a real challenge for us. So my folks taught me always that when you have a challenge, you always come up with a solution. Next slide. And that solution is what I call the 3 V's. The 3 V's of public health is really starts with, number 1, visibility. We have to raise the visibility of the work that we do. When we raise the visibility, it actually creates value. When you create value and people actually understand what you're doing, why it's important what you're doing, they actually then validate it. Validate it with either pro-health policies or pro-health funding. And I think that is absolutely critical. All of us can agree that we need to do more, next slide, to really build that capacity, which is really looking ahead at a well-recognized, well-resourced public health system that's strong, that's resilient, that's adaptable, and responsive to community needs. We can't do that if we don't take the first step, which is to really at times be out there to say what we do in public health, though invisible, is critical, just as critical as any of those other sectors that we always talk about, first responders, police, law enforcement, everyone across the system that we have an incredible amount of respect for, including the healthcare delivery system. But we have to also remember that we also need to be appropriately funded in order to be able to respond to our communities. That's how I would answer that question, Lynn.
Thank you. Elizabeth, you marshal other invisible troops.
Yes,
right?
yes.
If you can talk to us a little bit about that, this idea of shifting focus toward long-term recovery.
We do long-term disaster case management, so we're like a life coach with families, and we're in 17 counties in Texas right now, and Harris County is one of our big counties that we're serving, and we're doing Hurricane Harvey recovery. And people forget, after the storm's gone, it takes years. So we work with other voluntary organizations. FEMA helps, but FEMA's not the save-all. They can only give a limited amount of money because it's mandated by Congress what they can allocate. And so it's really the voluntary agencies long-term that come in and help rebuild the homes. FEMA may provide some of the funding, but the voluntary agencies help with the rebuild. St. Vincent de Paul has a program called House in a Box where we provide new furniture to families once the Methodists have rebuilt a house or the Mennonites have rebuilt a house. But I think the long-term impact to families, and if I want to talk a little bit about behavioral health issues. After disasters hit, a lot of people don't have the skills or the mental resources to cope. And surprisingly, we see middle-income families go into situational poverty because their homeowner's policy doesn't cover the storm. We saw that a lot in Harris County, where people overnight became poor, and they didn't have the skills to deal with that. They weren't used to, they'd always paid their bills, they'd worked hard, and all of a sudden they're in a situational poverty area. So we see domestic violence go up after disasters, we see hypertension issues, and unfortunately we see suicide. And these are all the kind of the hidden areas that people don't want to talk about. It's not sexy, it's not on the news, they're not out in the wind, the reporters aren't discussing this. But these are the long-term issues that we need to look at as Americans, and how can we address that? And the voluntary organizations, we walk with the survivor for a period of up to 2 years to help them plan their own recovery. And the other thing I would like to emphasize is that it's just not the personal impact, it's the impact to communities. When you lose your tax base, it's very difficult for communities to come back because you have people that leave that community because they can no longer, they walk away from their homes. They can't financially afford to be there. They don't want to mitigate and maybe put their home up 17 feet. So there's all kinds of issues. If you look at it from the school system to the Chamber of Commerce, it's important for us to look at what can we do long-term to help to put together some economic recovery for those communities, because if there's no jobs, I can case manage all day long with the family and I can help get them whole, but they have to be able to go back to work.
I'd like, if it's okay with the panel, to turn to the audience now. If you have questions, we have one last comment from the panel, but if you can raise your hands, and the staff will bring around microphones. But Bob, your response.
So again, focus on what can donors do. And here I'm thinking of both institutional donors as well as individuals. And the first is to think about it, plan a little bit before you act. We've got to get out of this reactionary position in dealing with disasters. But if you're a foundation or a corporation, plan ahead, put money in your budgets, have a committee that you work with, be more intentional in your giving as opposed to reacting and trying to do something very, very quickly. Your dollars, in fact, are probably more valuable if you wait a week or a month than if you feel some urge to give right away. Second of all is we will approach a donor who's made a contribution for a disaster-related activity, and the reaction always is, oh, we're not disaster philanthropists. And we'll say, well, you just gave $1 million to Harvey activities. They said, well, we just kind of like did that because the other banks in our town were doing, we felt a sense of pressure to give, but we're not disaster philanthropists. And then we'll say, well, so what are you? What is your thing if you're not disaster philanthropists? And they'll go, well, we're into kids, or we're into health or mental health related issues. And we'll say, well, if you can begin a discussion with someone about, well, what happens to kids, do you think, during a disaster or after a disaster? Or what happens on mental health issues when you lose your home and maybe lose a loved one and maybe lose your job? And so we're trying to get people to understand that we're all disaster philanthropists, whether that's our our daily job, or if it's only something we do occasionally, but we're all disaster philanthropists because disasters affect every part of our society, and we all need to be involved in thinking about disasters long term.
Thank you for that. So, are there any questions in the audience? Yes. Okay.
Hi. It struck me on your slide with the percentages, how small of amount of money goes to preparedness, and it's sort of that reactive question, and how we can sort of make preparedness to me is positive.
Sure.
If we could change the mindset from a reactive to just a preparing for it, and then also I work with senior citizens, so I always see going to the children thing. Everybody always responds to the children, and the senior citizens are like hung out to dry, and those isolated seniors are, whether, we see the horror pictures from the nursing homes, but how we can sort of focus more on preparedness to protect everyone.
I think it's a
So I
good
think
point.
part of it is we don't have the stories to tell yet. It's kind of to your point about the visibility. When I make a contribution, immediately I know it's going, I see those pictures on television. My money is going to give people who are in desperate need food, clothing, and temporary shelter. That's something that's very specific. If I give money to planning, and I go back to my chief executive officer or to my board, and I say, we give $1 million in planning, and they say, well, what was the result of that, right? We don't have we're not very good at this point in telling the stories. And what I say to nonprofit organizations is you need to give me the projects, the specific projects and the specific programs you're working on with the impact of your work so that I can go back to donors to tell them something that's...
I would also say I don't think society as a whole has come to terms with the shifts in the risk profiles around where so many people live. I mean, the frequency and severity of storms and the way that that's increased, the frequency and severity of the forest fires, the fact that so many people are living in situations that put them at risk. We never thought of New York and New Jersey as being particularly at risk from big storms. I hope after Hurricane Sandy we do, but that we still don't see the efforts that we'd like to see all up and down the whole Atlantic seaboard around preparing for these events. And it's a mistake, and it's terrible when the first message that people have about preparedness is when they've actually gone through a major disaster. That's not the best way to learn some of these lessons. And unfortunately, I mean, I'm thinking about Harris County and how many so-called 100-year floods have occurred in the past, 3 years?
3, yeah.
And
2015, 2016, 2017.
And people, you logically think a 100-year flood occurs every 100 years, but the probability of those has gone up.
Yeah, it was Harvey was a 500-year flood and a 2,000-year flood rain event. So I mean, think about that. But I just to that point, I'm really amazed by our Harris County government leaders now who have begun shifting from resilience in a more infrastructure resilience mindset to human capital resilience. And I never thought I would see the day that there would be a dialogue at our elected officials meeting around the CDC's SVI, the Social Vulnerability Index. And you had robust discussion about the value proposition of utilizing SVI to look at where flood mitigation projects and also looking at human capital and human resilience. That's amazing. It's an incredible step forward. We have to remember as one of our at least would-be candidates for president says, the existential threat of climate change. That is really a backdrop of a lot of what we're talking about. That hasn't come up today, but we need to be thinking about what are these real steps that we need to be taking on the impact of climate on health and on communities, which over and over and over again becomes a challenge. But the invisibility crisis, that hashtag invisibility crisis, is exactly the root of the problem, is that we are having trouble articulating why you need to invest in the offensive line. Everybody is focusing on that, 96 cents on every dollar on that healthcare system, the quarterback. We've got to find a way to transform ourselves upstream so we can actually really invest in capacity building.
So we had a hand up in the front row. I'd like to give him a chance to come into the discussion.
Thanks. Yeah, one of the benefits of things getting worse, that these things are getting more and more common, that it could well be that it pushes us to be more forward-thinking, because the idea that everyone wants to deal with the disaster today, but when it's done, I'm not going to prepare for the next one. But we now are getting to realize the next one's right around the corner. So that's a silver lining in some ways. But the thing I want to ask you about is this, that it's very clear that the problem with the disaster world, unlike the emergency medicine world, where there's nothing that's an emergency in emergency medicine because you routinize, thing, that there are disasters in the disaster world. You hear all the time of people going down to Hurricane Katrina to be a volunteer psychiatrist and hanging out for 2 weeks waiting for somebody to tell them where to go and stuff like that. Coordination is an enormous, enormous problem. And that's something that up front you got to get figured out. And nobody's talked about that. The question is, who's the core that's going to coordinate? Because everybody wants to do good, and then, as you all know, that people get into fistfights. No, I'm going to be the one doing good. No, I'm going to be the one. I mean, this sort of. What do you think is the way to get over that thing? Because there's an enormous amount of capital that is invested that doesn't have the impact it could have because of that.
I mean, an interesting fact is that no one from the outside even can get in usually for the first half a day to a day. So the core initially, and where the most important things that need to be done can be done, it's the people in the community. And Elizabeth, I think it's your folks who are
Yes,
involved
so we
with
have
that.
the Voluntary Organizations Active in Disaster. We do coordinate, we do plan. As I said, we have a national VOAD, and we also have state VOAD. So for example, in the state of Texas, when we knew Harvey was coming in, we started calls 72 hours out. And what was each organization going to do? What is the Red Cross going to do in Houston in the mass shelters? What is Salvation Army going to do? Who's going to provide the feeding? What is St. Vincent de Paul going to do for the immediate relief? What is Baptist Men going to do? We have groups that bring in showers. We have groups that do childcare. So we do coordinate at this level. We work, though, through emergency management because there's an incident command system. And what bothers us is when we have groups that come in from the outside that do not go through that system, they create a disaster within a disaster. Their volunteers aren't vetted. We need to have criminal background checks because we have a moral obligation as a society to protect the most vulnerable among us. And so it's very critical that we get organizations to go through the formal process, and a lot of groups don't want to do that. But it saves lives, and it keeps the disaster less of a disaster, because for emergency management and public health, the worst thing is to have people coming in, and people can bring disease in, not in addition to criminal activities. So it's very critical to have that, and as you said, sometimes groups aren't allowed in. There's a reason for that, because we're trying to protect the populations we're serving.
So there was one
Can I
last.
just add on as
Sure,
well?
and if the mic can come, our last question. So go ahead, Nancy.
At the global level, we all come together and work in that coordinated manner through the UN cluster system. So when there's a humanitarian crisis, like WHO is the lead for the health cluster, and we're a part of that cluster along with, I think, about 30 other entities. There's a cluster around food security. There are different clusters. So, and based on an organization's kind of overall principles within the UN and their goals, they can serve as leads of the different clusters, and then we work together within that. And that incident management system, I think we've learned a lot from that, and have really been trying to apply that, as I mentioned earlier, with countries all over the world, so that we don't have to come in and set a system up, so that they know what that system is, they know how to activate it, and we can all work side by side in that same, like speaking that same language.
So we have all of a minute and a half, but one more comment, and then I'm going to invite actually Bob Ottendorf to give the last.
John Balbus with the
comment.
National Institute of Environmental Health Sciences. Very quickly, one of the consistent features of morbidity and mortality in the major disasters hitting this area has been the delayed morbidity and mortality from the failure of healthcare facilities. And I haven't heard that mentioned yet. I think there's a huge schism in this country, obviously, between the private healthcare delivery sector and the public health sector, and there is not enough investment in the resilience of the facilities themselves, which would make a huge difference. What ideas do you have for trying to overcome that investment gap and that schism?
I agree with you, and I would say, Nancy talked about the PHEP grant. I think the HPP grant funding that also has taken a decrease over the years from ASPR, the Assistant Secretary for Preparedness Response, is incredibly important. I think one of the challenges at the local level is bringing and braiding all that together, the healthcare, public health sectors coming together in the planning phases, so it's not just on game day, and certainly in the recovery phase. And I think all that is really very much speaks to the gaps that continue to exist.
So, Bob, I wanted to invite you to give us some last thoughts about this issue of resilience and preparedness. And
Well, I think we've heard from all of us today that there are going to be more disasters. They're going to be more frequent and more intense. We need to begin to plan. We need to make commitments now. We need to be thinking of the health-related issues that exist today. Populations that are vulnerable after a disaster are most likely vulnerable before the disaster occurred. They'll just be more vulnerable after the disaster. In our giving, I think, and in our investments of our dollars, I think we need to look for solutions that not only solve an immediate problem, but make those communities more resilient so that they're better able to withstand the challenges that come in the future.
thank you very much. Thanks to all the panel, and thanks to all of you for participating in this discussion with us. I wish we could have had twice as much time. There's so many important issues here to unpack, but thank you so much.